I'm Scott Slovic from the University of Idaho, and I'll be the moderator of today's one-hour event. We plan for this to be the first in a series of useful and engaging webinars for researchers, research administrators, and others who are interested in what we call highly integrative, basic and responsive research. As most of you who are attending this webinar probably realize, the HIBAR Research Alliance has a new website that describes the activities of the organization's 4 collaborative action groups, or CAGs. CAG number 2 is working to encourage the creation of new HIBAR research projects, and it is with this goal in mind that we're launching this webinar series comprised of presentations by experienced HIBAR researchers and administrators. We hope everything will go smoothly with this first webinar, but we've never quite done a presentation like this with panelists in 4 different locations and numerous attendees. So please bear with us as we work out any technical kinks that might come up. Before we start, I wanted to explain the structure of today's meeting. We'll begin with brief introductions to HIBAR and to CITRIS, the Center for Information Technology Research in the Interest of Society. Next, our featured presenter, Dr. Katherine Kim, will give us an overview of the HIBAR aspects of her research for approximately 20 minutes. We'll then have 15 minutes or so for Q&A, followed by a brief opportunity for Dr. Kim to offer any parting takeaways. And now let's get started. I'd like to introduce Dr. Lauren Whitehead, Professor of Applied Physics and Special Advisor on Innovation, Entrepreneurship, and Research at the University of British Columbia, to offer a brief introduction to the concept of HIBAR and to the HIBAR Research Alliance.
Well, thanks very much, Scott. It's a pleasure to be here, and thanks for everyone who is online. Scott has asked me just to say a few words about really the meaning of the term HIBAR research. All of this relates to the ideas that universities, of course, strive to solve societal problems, but sometimes there are difficulties doing so. And really, there are 3 things that contribute to that problem. They're all fairly obvious. The first one is that most university research is either fundamental or applied. And the difficulty with that is that, first of all, fundamental research is often too disconnected from real-world problems to be immediately effective or even in the long term effective for society. And applied research is often too short-term. So there's an obvious solution, but it's a solution that isn't common, and that is to carry out a time-honored research form that is called HIBAR, highly integrative, basic, and responsive research. So the characteristic of HIBAR research is that it is highly integrative by combining fundamental and applied research. And that combining is done in all 4 of the following key ways. So first of all, the people involved, of course, have motivations. And in HIBAR projects, they have motivation to discover new information, new knowledge, and also simultaneously motivation to solve problems. So both at the same time. The methods that they use are well known, but they're a combination of the traditional research methods known so well to all of us, and also more creative design approaches that are very beneficial in solving problems, again, simultaneously. Very importantly, the people themselves involved include traditional academic researchers, but also others who may not be academic researchers, but have a much clearer, deeper, hands-on vision of the problem. So visionary experts combining with academic researchers. And then lastly, timeframes. The HIBAR research has the characteristic that it's focused on long-term outcomes. It's not afraid of long-term outcomes, but there's maintained through that long term a strong sense of urgency. Again, a little tricky to have all those at the same time. But when you do, studies have shown that combining all of these characteristics simultaneously creates a powerful synergy that leads to a higher rate of breakthroughs in society. So some well-known examples of breakthroughs from HIBAR research, penicillin, the transistor, and the underlying research behind the GPS, the internet, etc. So HIBAR research is an exciting idea. Sometimes it's a little bit difficult to picture, and one way that we try to sometimes make that a bit clearer is to say, well, look, any given piece of research can be thought of as somewhere on the spectrum from theoretical to practical. So when you look at basic research projects, you find that they tend to have their emphasis clustered toward the more theoretical and less practical end of things, as they should. There's nothing wrong with this. Similarly, if you look at applied research projects, they tend to have their emphasis clustered toward the practical end. And although both of those are just fine, and they are excellent research, and we love them, they do tend to underemphasize a middle ground. And it's that middle ground where HIBAR research is centered, but it also broadly extends to both extremes of the spectrum. So not only is it better suited to combining all these things that I've mentioned before, but it also provides, in a sense, a better transparency between work on basic research and work on applied research. So we'd like to have more HIBAR research, and the HIBAR Research Alliance has a goal of making that happen. So specifically, the goal is to achieve within 10 years a system-wide fourfold increase in the fraction of research projects that are HIBAR. Specifically, to increase that fraction from today, about one project in 20, to, in about 10 years, one project in 5. And very importantly, while strengthening all other important forms of research. So that's the goal of the Alliance, and one of the important ways that we believe in helping to achieve that goal is to help improve understanding of HIBAR research and to enhance communication between those who are interested in HIBAR research and those who are already doing it. And a key component of that is, of course, the webinar series that we're now launching. So with that introduction, Scott, I'll hand back to you.
Thanks very much, Lauren. And now, also by way of offering a bit of context for Dr. Katherine Kim's presentation, I'd like to invite Dr. Camille Crittenden, Executive Director of the Center for Information Technology Research in the Interests of Society, to give a brief introduction to CITRIS and to talk a little bit about the seed funding provided for Dr. Kim's work.
Great, thank you, Scott. Good morning. I'm really pleased that CITRIS is able to contribute to this first webinar this morning. As Scott mentioned in our acronym, it really captures the mission of CITRIS, the Center for Information Technology Research in the Interest of Society. So both of those pieces are very central to our goals, incorporating technology advancement and core technology research while being mindful of its impact on society and wanting to direct our efforts to those technology fields that are going to have the most social benefit. And Professor Kim's work is one terrific example of that you will hear about. CITRIS is a research center of the University of California. We're based here at UC Berkeley and have close partnerships with the campuses at UC Merced, UC Davis, and UC Santa Cruz. And at UC Davis in particular, both the main campus in Davis as well as the medical center and health system in Sacramento are part of the CITRIS ecosystem, where we tried to bring together in the health example clinicians with data scientists and technologists and roboticists and others who are working more in the core technology field as well. So some of the research that you'll hear from Professor Kim about today was funded through CITRIS. We're one of the 4 institutes for science and innovation throughout the UC system. And part of what we do is to try to forge collaborations among faculty members and principal investigators at the 4 campuses by offering an annual seed grant funding, competitive funding process. So Dr. Kim has received awards on various occasions for really groundbreaking work and collaborative work between folks at the health system and elsewhere within CITRIS. So this is one good example of how CITRIS is able to support some of the goals of the HIBAR philosophy that Lauren laid out in his previous presentation, and why we feel that CITRIS's mission overall and this example in particular that you'll hear about are good examples of what HIBAR is trying to achieve.
Terrific. Thank you very much, Camille. And now I'm pleased to introduce Dr. Katherine Kim, an assistant professor at the University of California, Davis, with appointments in the School of Nursing and in the Department of Public Health in the School of Medicine, to speak to us about designing and initiating a HIBAR project, a researcher's perspective. And Dr. Kim will speak for approximately 20 minutes before we move to the Q&A phase of our webinar.
Thank you very much, Scott. Let me share my presentation now. I'm so pleased to be here for the inaugural event. I was really honored to be asked to do this and new to HIBAR myself. I wasn't familiar with this acronym before meeting with your organizers, and I was really pleased to know that there was actually a structure in place for the kind of research that I do with my collaborators. So I'm really happy to be able to share this with you. I'm going to start out by giving you a little bit about why I do the research that I do. So I'm both a health services researcher and a health informatics researcher. And I often use this framework to explain what we're trying to do with our research. And so in the example I'm going to give you is really mobile health to precision health and how I apply this framework. So when you do informatics kind of research, you really think about where you start. And you start with data. And data are facts and observations. They become information when you analyze them in a way that actually can provide something new out of those facts and observations. But then it turns into knowledge when you give that information context, right? When you give it meaning. And finally, our ultimate goal is really wisdom, which is giving that knowledge some value for the greater good. So I start with that framework in mind as I construct my research program. In the example I'm going to give you today, we're going to be talking a little bit about the methods of machine learning. And to me, machine learning is really about making computers more efficient at the kinds of computation that they do. And that really fits into this cusp between the information and knowledge components of my informatics framework. And then the ultimate goal is artificial intelligence, which is giving that knowledge value for the greater good, where we can try and complement what humans do as they try to apply this knowledge with computers and other kinds of devices that will help us to put that to good use. So in the specific example, I'd like to apply this framework to the study. And I wanted to actually start by, there were 5 characteristics that folks shared with me in HIBAR. And I wanted to illustrate with each of these pieces of my presentation how I think it maybe fulfills those. So one of those characteristics was providing valuable understanding. The example I'm going to give you is using telehealth to develop precision cardiac care. And we start with the data, which data is that we had access to were telemonitoring, patient-reported information, hospital data. The information was applying these computational methods. So we used both machine learning and digital phenotyping. Knowledge then was to apply this in context. So what we wanted to do in context was to be able to identify early warning signs for people who had heart failure, who had discharged and at home, but we wanted to see if we could identify early warning signs for either exacerbation or worsening of their condition, or things that might cause them to end up in the emergency room or back in the hospital. And then finally, where we are trying to go is to have some artificial intelligence that can really support us in developing wisdom, which is being able to have decision support and ways to actually intervene to help people stay healthy and to prevent readmissions. Another characteristic was that these were broadly applicable and generating many new ideas. And because what we're trying to do is really develop these precision cardiac care models, I bring to you this definition that comes out of work at the very beginning of the US Precision Medicine Initiative that was launched under President Obama. And one of the ways that they described this was that precision medicine is data-driven treatments as unique as the individual. Since I think not just about medicine and therapies, but I also think about health more broadly, I would then submit that this is also precision health, is data-driven interventions as unique as the individual. So we're really trying to generate ideas that could be broadly applicable for health models and care models by using these data science techniques. A third characteristic was that these things are thoughtful, creative, and visionary, and the fourth being that they're carried out in partnership with society. So when we started this work, it was actually about 5 years ago. And the research priority that this came out of was actually a stakeholder-driven project that I conducted, where we had a stakeholder advisory board of almost 50 people that were helping us to identify research priorities that could be addressed by using data and that would be patient-centered. And so our heart failure stakeholder group said that their goal for what we did with data was to support this overall population goal to reduce unwarranted hospital readmissions for heart failure by 25% by 2020. This is also aligned with one of our national health goals. So we engaged a much larger group than just those advisors in an online Delphi panel, and we brought together 120 stakeholders that included patients, clinicians, and researchers to help us take that goal and say, now, what are the research priorities that we should pursue to achieve that goal? And so this is really how we have carried this out in partnership with society. So it was not just the researchers doing the study, but we were partnering with those patients and clinicians in the field to help us define those priorities. Two of the priorities that our Delphi panel came up with were to understand whether and how care coordination activities could impact patient outcomes. And the other was to compare the effectiveness of remote monitoring and telehealth strategies for heart failure. So we took those research priorities to heart. So now what do we actually do with that? Well, this quote actually comes from a very large systematic review of technologies for remote monitoring in heart failure. It includes 3 narrative reviews, 7 meta-systematic reviews, and other systematic reviews of trials. It's quite dramatic to hear the final conclusion of the authors, which says, in sum, the literature on telehealth in heart failure is a policymaker's nightmare. It's vast, fragmented, heterogeneous, of variable quality, and with no clear answers to the question of what technologies, supported by what service infrastructure, to provide for whom. So that was really kind of dramatic. It says we really know so little about any of these aspects of applying telehealth for heart failure. And so we took all of that and we said, if we really want to change or impact the way that we provide care, and we want to apply the data science methods that we have, identify what kind of data science methods we need, what could we do? And so we came up with a specific question, which was, can we better predict readmissions with person-generated and dynamic data? So to answer this question, we went to data that came out of a large randomized clinical trial. This was called Beat Heart Failure. And it was a randomized clinical trial of telemonitoring applied to care management for patients who were discharged from the hospital when they had been admitted for a heart failure diagnosis. There are about 1,500 patients in this randomized clinical trial. And the data that we have access to were demographics, hospital and emergency department admissions up to 180 days after enrollment, and then person-generated data of these types. Remote telemonitoring at varying time points for up to 180 days, including remote telemonitoring of heart rate, blood pressure, and weight. And patient-reported outcomes and indicators that come from validated survey instruments. And there were 6 survey instruments that were applied, and we had data from a baseline survey, 7 days, 30 days, and 180 days after enrollment. This is a unique data source because person-generated data, those things that people generate either by active or passive monitoring of themselves, are rarely used in the health system and rarely accessible to clinicians or to researchers. So we were quite fortunate to have access to this kind of data. So again, to continue with this, this 4th characteristic of being carried out in partnership with society, and then the 5th, quickly solving a specific practical problem, we wanted to do the study. So again, the question was, can we better predict readmissions with person-generated and dynamic data? Well, I'm a health informatics researcher and a health services researcher, and I think about care models and health. I'm not a data scientist by training. And so in order for me to do this work, I had to partner for the expertise that I needed to answer this question. And this partnership really came in 2 phases. So in the first phase, I partnered with Raid Ghani, who is a data scientist at University of Chicago. But he started the Data Science for Social Good Center at University of Chicago. And in addition to his work there, he had independently applied to this program called Road Trip, which you can see the acronym there. And I had also applied to this program called Road Trip. And the purpose of this program was actually to bring together people from these different disciplines, to take biomedical researchers and match them with data scientists to try and solve problems and answer questions that neither could do on their own. So the funding for this road trip was only $4,000, and it was for a 6-month period of time. so that I could spend time in Raed Ghani's lab at Chicago and learn something about these machine learning methods. The second phase is a $60,000 intramural grant from Citrus, which you just heard Dr. Crittenden talk about. It was a $60,000 grant for a one-year project to do the second phase of this work, which is going to be around visualization. And my partner there is Quan Lu Ma, who is a computer scientist at UC Davis. And he also runs an externally facing center called Center for Visualization. And that center is also trying to sort of solve visualization problems that then can bring that information out to the public and to non-academic organizations. So you can see even my partners have this commitment to solving practical problems and working externally towards sharing that with society. So I won't go through the methods that we use so much, but it's to show you the kind of results that we got. So these are just, I will show you three results from phase one. So this first one was really trying to get at, when you have these patient-reported data from the surveys, how does that contribute to predicting a readmission? So predicting who will actually end up back in the hospital. And what we discovered was in this chart. So what you see is the different kinds of data streams that we had, and you're not actually seeing the names of the data streams, but I'll point you to is really the bottom row, which is the survey data stream. And then you see along the x-axis there, the prediction window. So how does it predict for 1 day after discharge from the hospital, 2 days, 7 days, 14 days, all the way out to 6 months or 180 days. And what you see is in the green is when that data actually gives you positive predictive value or positive value towards predicting a readmission. And you start to see that this patient-reported information about how they're feeling, about their level of confidence in managing their condition, about their health literacy contributes. And you start to see that green starting at 14 days after they leave the hospital. And it gets progressively darker green out to 6 months, which means it's very valuable all the way out to 6 months in predicting readmission. So that was pretty striking. The second result I'd like to show you is in terms of what's the precision level where this provides you some value. And precision level you can think of as, we did this at 10%, 20, 30, 40, and 50. At 50%, it's kind of like random. It's no better than random. At 10%, you think of it as the top 10% of people who might be readmitted. And then we also did this at the specific timeframes. So this result shows you the 180-day timeframe, which is all green all the way to the right. And at every precision level, from random all the way up to the top 10% of people who you're most confident are going to be readmitted. Again, those patient-reported information give you value at every precision level at the furthest time frame out. So again, the importance of what people tell you about themselves for predicting readmission. And then one last result. Now, since we started out saying, what does telemonitoring tell us about these patients? Well, this is how telemonitoring improves prediction. Again, the prediction levels in the rows are 10, 20, 30, 40, 50%. And then the time frame along the bottom. So the arrow shows you that telemonitoring gives you high quality predictive information for the top 10% of people that are most likely to be readmitted. So it gives you a sense that you can start to try and identify those people that are going to benefit from telemonitoring. And so rather than try to give telemonitoring to everyone, because it's a very expensive resource, it requires effort on the patient's part as well as on the health system's part to monitor for long periods of time. Rather than try and say everyone should be telemonitored, this gives us an opportunity to start honing in on the people that will actually benefit from telemonitoring, where we might actually intervene to try and do something early so that they don't end up back in the hospital or the emergency room. So that was phase one. Phase two, which is the work that's being funded by Citrus currently, is to take this information, which is quite complex to understand for researchers, let alone clinicians who aren't used to seeing these kind of data, and patients themselves, to take that information and find ways of visualizing it and communicating it back to clinicians and patients so they can interpret their own information and take that information from knowledge to wisdom themselves and integrate it into their own decision support, into their conversations with each other about treatment planning, and potentially into systems that automate decision support. And so you see some examples of sort of typical ways that we communicate this knowledge through graphics. We want to go beyond this to make our visualizations very intuitive and interactive and useful for people as they make these decisions. So the final piece of information that I'd like to share is in this last characteristic, which is motivated and informed by societal issues. And I have permission to use this photo and to tell you the story. This is Hugo Jr. and Hugo Sr., father and son. Both of them have heart failure. Hugo Sr. is in his 80s, and he moved here from Brazil and speaks only Brazilian Portuguese, does not speak English, and does not speak European Portuguese. Hugo Jr. has lived here for quite a while, so he is fluent in both Brazilian Portuguese and English. But he is his father's primary caregiver. He takes him to all his appointments. He monitors all of his health issues. He helps him with his medications. He keeps up on all of his lab data. And the challenge is that Hugo, as part of our stakeholder panel, came to me one day and said, I do all this on my own. I collect all his medical records. I scan them. I keep them on my laptop. I have spreadsheets. You know, I try to bring everything together. And I do that and spend a lot of time doing that to help him. He will never be able to understand this data on his own. How do I help him to stay as healthy as possible without putting this burden on him, you know, to become knowledgeable about all of this data? That was one of the reasons why we really paid attention to this phase 2 in particular. And so it's motivated by helping patients like Hugo Jr. and Sr. and helping caregivers like Hugo Jr. To be able to use this data to make the best decisions. Thank you.
Thank you very much, Kathy. And you were quite efficient with your time. So we have plenty of time actually for Q&A. And so thanks very much. That was really interesting. I have several questions kind of to seed the Q&A period, but I'm hoping also that we'll receive some questions from others who are attending today. But let me start out by trying to tease out some of the other HIBAR aspects of this project, building on what you've already said. As you know, one of the essential aspects of HIBAR research is the relationship with partners, and not simply recipients of the information, but people who are fully involved in developing the research and collaborating together with the academic researchers. So we have a few questions from Ron. I'm wondering if you can go back to the very beginning, the idea of where the research question came from, and talk a little bit further about whether you had this question in mind from the beginning or whether it emerged through conversations with partners, people,
Yes.
or other or practicing physicians. And the other question is whether you began with an existing research question that you then added to this. Push a little bit further on that?
Yeah, thank you for that question. So as I said, this initial stakeholder engagement process started about 5 years ago, and I was doing nothing in heart failure, and I did not see myself as a data scientist in any way. So I did not start out. I had other research questions that I was hoping people would come up with, but I didn't go into that process thinking, you know, how this was an interest already. So we were really genuinely completely open to what the stakeholders suggested and to the priorities that the Delphi panel ended up recommending. And we actually had 3 conditions that we had proposed this sort of process with. It was weight management, heart failure, and Kawasaki disease. So 3 different conditions. So it was really completely open as to where the stakeholders were going to go. So when the stakeholders came up with that goal of reducing heart failure readmissions or cardiac readmissions, we went with them and said, okay, if that is the goal, then what priorities would you have? And the priorities came from those stakeholders. And this 120 panelists went through 3 rounds of information sharing, discussion, voting online to prioritize all of that information down to top 3 priorities. So I just shared 2 of the priorities with you. So it was not, there was no a priori decision about that. In the same time, then the part that I did not talk about actually is as those priorities were emerging, we actually started talking to other people. We started talking to our hospital leadership and our research leadership. And they weren't part of the consensus process, but we said, what do you think about these priorities? What does that mean to the health system? What does that mean to other researchers in our own health system that might want to do this work? And so we started having these informal conversations, some formal and some informal conversations with them about that. And the applicability of potential answers to the question we ended up with was, can we predict readmissions, came from one of our health system senior leaders who is a very big advocate and supporter of remote monitoring and telehealth. And he said, we know this work is not really cost efficient. In fact, it adds cost. But if it can really have value to patients and improve outcomes, we're willing to invest those resources. But is there any way to know who is it going to help and who is it not going to help us sort of target our investments to the right people? So that as a potential impact for the health system, then added more weight behind answering this question that came out of the patient and clinician stakeholders. So we didn't start with it. It really evolved organically out of the process that we launched.
That's great. Thank you very much. That's so interesting, Kathy. And related to that, Ron also asks a question about the results that are emerging vis-a-vis partners, and whether your ongoing communication with partners has somehow validated or indicated the usefulness of the data that you're gathering, or is it perhaps too early to really tell that?
Yeah, so from the first phase is done. And so we have started external communications around that first phase, which are what are the value of these different data streams for the prediction. And so we have, talked about it at some conferences, and we've shared it, informally with vendors, companies that we've met at these conferences. And we've gotten quite a bit of interest from vendors in, can we actually take those algorithms? Can we take the findings and build them into our systems? That then brings a whole other set of conversations with the university about licensing. Can you license, the results of an algorithm? Is that intellectual property or is it not? So we're not exactly sure where to take that, but we'd be really happy for that information to get out, to the technology community so it can be applied, because we don't know really how the algorithms and decision support systems are built because they are proprietary. We really don't know how good they are in many cases, and we can't necessarily test it because they often don't want to expose their own algorithms. So if we can contribute something to their algorithms that are based on research data and research results, and we think it would improve it, then we're happy to do that. But the other way that it's getting out there is Raid and I have talked about doing this next step, which is we think that there are many questions that could be answered using a very similar approach to what we took. And that the algorithms are actually based on fairly common machine learning algorithms that you can find that code in many places. We have certainly refined it for answering this type of question, but we're going to take all that and put it into a toolkit where we can take the code, we can take the notebook, the Jupyter notebooks, we can actually take the instructions for how a non-computer scientist can prepare their data to run them through this toolkit and let other people play with that. We could potentially let patients who have access to some of these sort of citizen science generated data sets, or these N of 1 quantified self data sets that people are collecting on themselves, we would be happy to make them available to that community so they could actually run their own their own experiments through these kinds of toolkits. So we are working towards putting that together both for other researchers, sort of biomedical researchers, and then for the citizen science community to see what they can do when they have access to it. So we are very interested in all three of those options. It's not something that we think we're going to build a company around, but we think it has value if it can be disseminated.
Thank you. And since you mentioned Raid, that raises or reminds me of another question that we had already prepared before the webinar, which is about the challenges of bringing together academic disciplines that don't typically work together. And it sounds as if you and Raid, working from a public health perspective and a data science perspective, have found a way to collaborate particularly well together. But I wonder if you can talk a little bit about any of the challenges you faced, if there were any challenges, or if it was just a seamless process of immediately grasping the other disciplines and vice versa, so that the disciplines came together for your project. And if there were any challenges, what advice do you have for overcoming such challenges?
That's a really interesting question. So I think so. In one ways, I think our partnership worked because we both had some similarities in our backgrounds, not in terms of content expertise, or methodological expertise, but in the way that we have approached our work. So I spent over 15 years in industry before I came back to get a PhD and come to academia. So I worked in hospitals and clinics. I worked in technology companies. And so I was really used to working with often people who knew way more than I did and people who knew way less than I did, and always trying to sort of bridge that gap of what do we know together and how do we make it apply to a question or a problem or a project that we need to do. Raid, as a data scientist, and his center, which is Data Science for the Social Good, he works with local governments, city governments, police departments, other nonprofit organizations to help them learn about these data science techniques, to apply them to questions that they have about their own work. And so he also is similarly always working with people who don't know much about his field. And so in some ways we had that perspective coming in. But I'll tell you about a specific challenge. So I don't have any computer science training. Actually, that's not true. I took a computer science class in 7th grade. That was the last time I did programming. So he started out by saying, here are some online tutorials that you can take. Here are some massive MOOCs, some massive online courses. Go ahead and teach yourself Python, which is a programming language. And I dutifully went in and started working through these, and I was very quickly lost. I didn't understand. I also didn't see how that was going to get me to answering these sort of really complex questions, because it was taking me sort of step by step through programming. And I felt like it was going to take me years to get to a point where I could even answer a simple question that I had. And so I called him and I said, this is just not working for me. I keep getting stuck and I'm not seeing the relevance. And we decided, rather than waiting till when I had originally scheduled to go spend time in his labs, I was going to teach myself Python first and then go. We decided I would just go and be immersed in his lab and hang out with his students and with his interns and learn it by being there. And that way, whenever I had a question, I could ask. And I could be teaching them about the healthcare system, about this particular condition, and about why I was asking these questions. So there would just be this mutual exchange. That worked incredibly well. So I went for 4 days. I think it was 4 or 5 days the first time. And I just sat there every day with them. And through that exchange, I learned really quickly. They really learned why this was so important and how the data I was bringing was so different from the data they were used to. Often they were working with like social media data or, police records, other kinds of data, but they were not used to healthcare data. And so that really bridged that gap. We got to meet each other. We got to work together. We got to know each other really well in that short period of time. And then that just propelled me forward. I really kind of got it in those 4 days. And then I came back home and did a lot of work. And then when I went back for the time that I was originally scheduled to, we were able to make progress very quickly. But I think it was that bridging that gap of what I was being challenged with, the way that they would typically learn, it was not working for me. And what they knew about my question and my data, they kind of didn't know what they didn't know until I was sitting there with them and they could explore it with me. So that was a challenge, but that was how we fixed it.
Yeah, so it sounds to me that really the key was investing the time and making the effort to actually be together with your partner from another discipline and making the effort to learn the other person's discipline, at least to a certain degree, so that you could understand the questions in order to present your own work, your own discipline in a useful way to your partners.
That's right.
So you mentioned that you started your career in industry and then moved into academia. And I actually have a question from Camille that's related to your life in academia as you do this kind of work. And she asks specifically if you have a sense of how the kind of work you're doing is being evaluated as part of the tenure and promotion process. And it may be too early to really determine this, but surely you've had conversations with colleagues or department chairs about the kind of work you're doing, and maybe you have a sense of the way the institution is embracing this work, supporting it, or questioning it. Do you have a sense of that at this point?
Yeah, I think in general, people have been very supportive of it. And I think a lot of people will say this interdisciplinary collaboration is valuable and meaningful and helpful, and they are in support of it. But often when you say specifically what's valuable and specifically what do you measure when you say that or review work that somebody's doing, people aren't quite sure. Like, I don't get extra points in my tenure packet for having collaborators outside of my discipline. I still get evaluated on the same metrics, papers and students and impact factors and, all those kinds of things. So I don't get any extra points for this. Maybe qualitatively I do, but there's not really extra quantitative points. Not that we actually use points, but so I think it comes through more in comments. So I will give you an example. And I'm actually going up for tenure this year. So maybe next year we'll find out whether it makes a difference or not. Someone made a comment in one of my previous sort of merit reviews where they said, well, she has her publication record is just fine, but we noticed that there are a number of conference papers, conference proceedings, not journal publications. And so they said we would sort of count the journal publications, when we say those are real publications, but the conference proceedings, we're not sure. So we would kind of discount those. Well, in computer science, they do almost all conference proceedings and much fewer of these, or much less of these conference proceedings. And so we've had to have conversations about where do we publish, that's good for me versus good for you. Because I know that belief is out there. So we've had to negotiate that a little bit. So I think there is some qualitative difference in when people say cross disciplines. Is it a good journal? Only this discipline knows, that discipline doesn't. Is it a good conference versus a journal? So we have those kinds of issues. The second is, so I think that is sort of across disciplines when everybody's in academia. Now, across disciplines when some of your partners are not in academia, like the patient partners that I work with, like those stakeholder groups, it's a different calculus, right? There are definitely no points for collaborating with community, because often that collaboration with community does not yield a publication. It may not yield a grant for many years, right? It took us almost 4 years from that stakeholder work to get to the point of even the small intramural grant, right? And so if you have this collaboration that yields no grants, no papers in 4 years, you might as well not even put it in your packet, right? So while some people say it's nice, it's not going to get you tenure. And so there is some commitment to doing this work where you won't get any credit when you go up for a promotion or merit review. But I do think in general, people are supportive of it. They see the promise of it. It's just when it comes down to it, will that count or not count? It's a little hard to know.
So you said you're coming up for tenure and promotion this year, and you'll probably have to write some kind of personal statement for your packet. And I'm wondering whether you're thinking that you'll actually include some information explicitly about the complexity of working across disciplines and between academia and partners in society as a way of explaining to the readers of your packet, or educating your readers or the senior administrators at your institution about the kind of work that you're doing, because it may not be entirely a conventional packet for someone in your home discipline.
Yeah, I think that is a good idea. I think what would be even stronger is, and it points to the importance of the work that you all are doing, is if the senior leaders of schools and departments could actually write that in their letters for their faculty. If they could say, this is important to our work, this is important to our school, and this is why we think it's deserving of attention and focus, I think that holds more weight than me just saying, I think it's good because of this. If my dean puts that in the letter, it will be much stronger.
I think that's a great suggestion, almost marching order for the HRA to work with senior administrators to try to develop that kind of language.
Yeah.
A matter of institutional policy. So a related question has to do with funding. You have some seed money, and I don't know the entire range of support that you have for your research, but Camille also asked the question about what kind of follow-up funding you have in mind in order to continue this work. Do you have some agencies in mind that would be particularly open to this type of work, or is it also complicated to find an agency that would appreciate this sort of multifaceted research? What are your thoughts about that?
Navigating funding is difficult for everybody, no matter what. So it is definitely a challenge. For me in particular, I've been used to seeking funding either from NIH or from technology foundations or other research-oriented foundations like Robert Wood Johnson Foundation. They're used to seeing these sort of collaborative projects. In this area particularly, where we're looking at data science and predictive analytics, that right now is getting a lot of attention. And so we can apply to NIH and we can apply to NSF, depending on the question. And so we have plans for this, but the process of going through this work on this project has actually launched a whole nother area for me in applying the same kind of community engagement, the same kind of cross-disciplinary collaboration in cancer predictive analytics, which again is a new area for me. And in that area, we've already taken some of the things that we learned from the heart failure work, applying it to cancer and applied to the NSF Smart and Connected Health funding program. And that's a collaborative NSF and NIH. And they particularly are looking for these kinds of transdisciplinary problems that have both a fundamental scientific question you're asking, as well as some translational value to health. And so that's a pretty unique program. And so we've already submitted one grant proposal to them. And again, there are some foundations, some very sort of innovative foundations that will fund this kind of work too. If it's technology development, it's much harder, because developing software, developing technologies takes much longer time. So it's a little more challenging there, but when it's analytics, I think we have a few more places we can go.
Thank you. Yeah, Lauren, why don't you present the question? Thank you.
Sure. There really are three. The first one is from Rob Rolling, and he says, you state a stakeholder goal, 25% reduction by 2020, by polling a fairly large group. So one, why did you decide on this timeline, which is pretty short for academic research? And two, were you tempted to adjust the goal and the timeline as the research progressed?
Oh, that's a great one. So the goal is actually, the stakeholders that we engaged with came up with the goal. So they said they wanted to adjust, they wanted to affect readmissions, they wanted to do it in the short term, they wanted some reduction. So they gave us the parameters. When we got the parameters and we went and, we are very familiar with our, our national population health goals. And we said, this sounds very much like one of our national 2020, population goals. And so we went and pulled that. So the wording that you actually see is the national goal, but you recognize that this was done 4 years ago. So we brought that national goal to them a few years ago and said, does this sound like what you all were getting at? And when our stakeholders saw that, they said, that is exactly what we were hoping for. So we actually just adopted the national goal because it fit so well what the stakeholders wanted. That wasn't the case in other conditions. So for Kawasaki disease, there was no national goal. So they constructed one themselves. So the second question was, were you tempted to adjust the goal and the timeline? We had promised that we weren't going to adjust what the stakeholders said. So we actually made a commitment up front to all the stakeholders that what you agree on as the goal and the research priorities, we will not adjust those. We will do our best to develop research that will at least get us on the path toward achieving that goal. And they understood that often research projects take 5 years to get done. And so we might not achieve the goal with that, but we would have made our contribution as one step towards that goal. So whether we might have been tempted, but we had committed that we wouldn't do that.
There are a couple of other questions. One of them was basically already covered. It was an excellent question, but also excellently answered by Kathy. And there's one left, which is from Gretchen, and I'll read it. Health services research lends itself to HIBAR more readily than other areas of basic research. Do you agree with that statement? And then, are there other areas of basic research that are also more likely to do HIBAR research?
Yeah, I do think health services research maybe just naturally could lend itself, but I think about other areas, sort of clinical research on, new treatments, medical devices, the other things that I work on, things like care coordination and supporting family caregivers, which some people might say that's health services. I think of it more as more health and clinical research. I think those things could also be improved and strengthened by the HIBAR approach. And particularly because especially at the early stages of coming up with the question, often we do it from our own expertise as researchers, and we don't engage with industry, we don't engage with the citizenry, we don't engage with patient populations to really understand what the long-term translational value, the long-term practical value might be. We just think about the next grant and the next project, right? And so for us to think that long-term, what would I actually be able to do if something like this were successful in the long term? That's where that engagement at the early stage, I think, could really help us refine what our questions and refine our study purpose. So I think there are a lot of areas that could benefit from that approach. So not just health services research, certainly in technology development. I think that would be really, really valuable. And we also seek to do that in health informatics and technology development, but maybe not as much as we should.
Yeah, I just wanted to expand on that last question a little bit beyond the health sector, and to say that when we're thinking about HIBAR research, we want to think fairly expansively about that as well. So just some other examples might come from, say, the energy sector or transportation, say, where you're developing new sensor networks that would then have application in predicting water availability or droughts, or predicting traffic patterns. So really anywhere where you can merge that kind of technology development with an impact on society. There are lots of other examples related to, say, AI development, and how are we thinking about ethics and values around deployment of AI tools and algorithms across a number of sectors. Health is a great example, but there are others as well. So I just want the folks on the call to think a little bit beyond the health sector as well when we're thinking about HIBAR research, because there are a lot of different kinds of applications.
Excellent. Thanks for that contribution, Camille. And Kathy, I wonder if you have a parting message, parting words of wisdom for others who are considering HIBAR research.
Yes, thank you. I do. I have three. I'll take my 3 minutes and give you 3 points. My first point is to build bridges, not just grant proposals, and to build those bridges across academic disciplines, between academia and industry, and between professionals and citizens. I think that sort of societal benefit, that societal perspective really needs sort of bridges across all of those different dimensions. And often researchers think about building the collaboration in time to write the proposal, right? We get 6 weeks and we're rushing to find the collaborator to write the proposal. And I think good collaborations aren't built in 6 weeks. And so that's my first piece of advice, is to build those bridges, not just for the proposal, but to think about what you want to accomplish in the world that research and the proposal might get you towards. My second point is directly from my experience at having gotten this funding and having done these 2 projects, the second of which is in progress now. And that is that these sort of small funding amounts, whether it was the first $4,000 I got or this current $60,000 grant, that the value of that is to build capacity for transdisciplinary research. It's to build that capacity and help set the foundation for that big transdisciplinary leap that will come in the next phase. But if you don't build the capacity, you won't get to that leap. And so the road trip program from the NIH funding and the Citrus grant is really helping us to build that capacity. And the final point is that I do think that leadership vision and programmatic contribution is really needed. If NIH hadn't thought about this road trip funding, if Citrus hadn't started the seed grants, if other programs didn't think this was important and valuable and didn't give time and effort to building programs that helped it along, my research wouldn't be here. And I would be struggling on my own to try to figure out, how do I answer these questions? So I think that leadership vision, that programmatic infrastructure is really key. And I think that's why this HIBAR group is really important to building that. So those are my 3 points, and thank you very much.
That's terrific. Thank you very much for your presentation, and I think for providing guidance and motivation for the HRA as we move forward, not only with this webinar series, but with our other efforts. So this has been an excellent start to our, what I hope will be a successful series. Thank you very much. And thank you to everyone who attended today's webinar. And please stay tuned for announcements of future events in the series. Thanks very much.